everyone, welcome back to the Orthopedic Tutor channel. Today we'll be talking about the lumbar canal stenosis. Well, based on its names here, you could already suggest that this condition is a stenosis, which means there is a narrowing, and the narrowing occurs especially around the canal or spinal canal over at the lumbar vertebrae region. Now, before we go on to the basic discussions regarding its basic diagnosis, management and post-management program, I just like to show you about these different anatomical pictures. You could see here that there are three basic types of our spinal canal. So the ones that has a round shape, the one that is ovoid, or the one that is in trefoil shape. Now, this explains why certain individuals has the tendency to develop lumbar canal stenosis, while the other has no or less frequency or tendency to have this condition. Now, once again, these are all normal variants of human being. Now, first, I would like to cover the basics first. Based on the epidemiology, this stenosis could be divided into the ones that happen in the congenital group age and also the one at the acquired group age. Now, in the congenital ones, usually any congenital anomaly that distorts the normal spine anatomy could cause stenosis, and in the acquired one, usually the degenerative cause remains the most common cause, and it usually occurs around the 6th and 7th decade. While per definition, the word stenosis actually comes from the Greek word, which means that there is a narrowing that occurs at the spinal canal. And there are also two types of stenosis, which is called or known as the tandem stenosis or absolute stenosis. When the spinal canal has reached a diameter of less than 10 mm on its AP diameter, we call that as an absolute stenosis. And if there is a occurrence of both stenosis over at the cervical and the lumbar region, and it could present as a neurogenic claudication or radiculopathy or myelopathy, we call that as a tandem stenosis. Basically, it is stenosis over at two different regions, lumbar and cervical. Usually this occur at around 15% of all the lumbar canal stenosis case. Now, etiologic wise, usually it could be caused by several things. It could be a congenital cause. It could also be an acquired condition, or a combination of both. For the congenital ones, it is usually caused by an idiopathic cause or achondroplastic. We could see that in achondroplasia, there is a growth disturbances of the whole body, and we could see that generally the shortening of the vertebrae itself it would virtually lead to a narrowing of the spinal canal, and therefore for this subset of patients, usually at a much earlier age, such as in their second or third decade, they may present with canal stenosis symptoms. Now, for the acquired one, generally you would say that it can be caused by various causes, but one of the most common one would be from the degenerative causes, or it could be secondary to other conditions, such as in the Paget disease, ankylosing spondylitis, or even the acromegaly. Now, the next cause of acquired lumbar canal stenosis may be from other causes such as slippage of the vertebral body, which cause narrowing at the posterior aspect, or it could even be post-traumatic. Now, for the Kirkcaldy-Willis theory, this theory is the basic theory that leads to how a degenerative spine came to be. So basically, when you look at a spine, you could imagine that this spine has three legs, and the legs will consist of, the first one would be around the vertebral disc and vertebral area. The second and third would be the right and the left facet. So these 3 points makes up the stability of the connection between the vertebrae. And in the Kirkcaldy-Willis theory, it is mentioned that the degenerative usually starts around the disc, and it is becoming degenerated, and usually the two table the leg of the table itself will become unstable because one aspect of it is unstable. So you can imagine that a table with only 3 legs on it, it cannot stand when one of it is disrupted. So when this disc become degenerated and it leads to instability over at the anterior aspect, the posterior facet joint will also become affected, and therefore degenerative cascade will occur at all those 3 points. Now, for the classification scheme itself, you could usually classify it based on the location of the stenosis itself. It can be a central stenosis, foraminal stenosis, or even the lateral recess stenosis. Here is a picture depicting these 3 types of stenosis. We could see here at the central canal stenosis, it occurs at the central region, and it can be caused by hypertrophic ligamentum flavum, sacral sac compression, or even the central bulging of the disc. While for the foraminal stenosis, usually it is caused by intraforaminal disc extrusion causing nerve root compression. While for the lateral recess stenosis, it is usually caused by the articular facet overgrowth, and these are usually triggered by any degenerative changes. Now, next would be how to diagnose this condition. History taking will usually reveal that the patient has a history of neurogenic claudication. There could also be other symptoms such as pain, numbness, or giving way, along with radiculopathic sign. Now, when we talk about the claudication, the neurogenic type, you need to differentiate it with the ones of the vascular cause. Now, for the neurogenic type of claudication, usually walking will induce a more proximal to distal thigh pain. Remember, it is situated over at the higher ups around the thigh, while for the vascular claudication, the calf pain dominates. And for the uphill walking, because you are giving up more energy to walk uphill, usually in the vascular claudication symptoms, it will develop sooner because the vascularity of the muscles are disrupted, and the muscles therefore will experience sort of like an ischemic attack, and the symptoms will develop. While on neurogenic claudication, these symptoms typically develop later. Now, for the other symptoms such as lying flat, usually we lie flat on our bed, then usually patients with vascular claudication will experience relief because that due to the resting nature of lying, the vascularity is not needed. Not needed, but the muscle does not need so much blood supply anymore because it's not doing anything, and therefore the patient experiences relief. While on the neurogenic claudication group, the patient may have symptom exacerbation. We need to know why this happened, why the symptom exacerbates while we lie flat. It is because that in the patient itself, you already know that the patient has compression over at the posterior aspect, and when we lie flat on the bed, usually the lumbar goes into a lordotic curve, and therefore this area becomes even more narrowed because all this hypertrophic ligamentum flavum and so on will go inwards. It will infold inwards to the spinal canal and therefore makes it more narrow. That is why patients with lumbar canal stenosis usually enjoy the position of hunching forward, because when they hunch forward or they bend forward, usually this area opens up and therefore there is less compression towards the neural elements. The next thing we need to know is how to do a proper physical examination. You need to do some tests for tension sign, such as the straight leg raise test or LASEK test, because it usually helps you detect whether or not there is abnormality at the nerve root. Now, usually during the physical findings, you can find that the spine is unable or limited in its terms of extension movement. You could also do another test called the standing treadmill test, which usually stimulate a dynamic strain on the whole body, and patient with stenotic canal usually has decreased walking distance. Now, the workup for this type of condition includes the basic things such as plain X-ray, which will reveal any evidence of this degeneration, also along with loss of the lordotic curve or any degeneration of the facet joint. Other things that you could do include CT myelogram, and this will reveal any osteophyte formation along with the study of the canal morphology itself, which is this one. Okay, the next thing would be MRI. MRI is good because it helps you identify any hypertrophy of the ligamentum flavum, foraminal stenosis, and also nerve root entrapment. Now, you need to know that even though MRI is the examination of choice in evaluating lumbar canal stenosis, a huge group of patient population without any symptoms may also reveal abnormal MRI finding. Therefore, it has a high false positive finding. So you need to remember that you only can correlate the MRI finding as in related to your diagnosis if the patient has positive symptom. If the patient does not have any symptom and you just take an MRI and it reveals a canal stenosis, you cannot say that the patient has a canal stenosis because this is once again a clinical finding. The patient needs to have symptoms such as neurogenic claudication and so on. And next, we are going to move on to the management plan. While this condition may sound severe, usually it can be successfully treated with non-operative modalities such as the lumbar epidural steroids, transforaminal block. These are all injections that you do on the spine. You could also go on an easier method such as resting, and SAID weight reduction, and performing Williams flexion exercises. Now, the reason why you need to do a Williams flexion exercises such as shown in this picture, which includes various movements such as pelvic tilt, sit-up in knee flexion, single knees to chest, seated reach to toes. You do all of this to strengthen your flexor muscle, especially the abdominal muscle, which help flexes our lumbar spine. Once again, muscle imbalance has been an important factor in determining the prognosis of a lumbar function. So when you have a lumbar spine, a good bony anatomy of a lumbar spine, but you have a weak muscle, a poor discoordinated muscle that is around the bone, then there will be instability of the spine because the muscle power that determines how stable the spine is. And usually patients with canal stenosis, they may also have a big belly, a big tummy over here with weak abdominal muscles, and therefore the spine extensor will dominate and the spine will go into a lordotic curve, and therefore it will exacerbate the symptom. So when you do a Williams flexion exercise, you actually want to reverse the curvature of the spine into a more straight position or not in hyperlordosis. Now, the next thing that you could do is operative management. Operative management is usually indicated when there is positive study results from your MRI. When there is one of the most important indication for performing surgery is if there is persistent, unacceptable impaired quality of life due to the pain, which also may be accompanied by progressive motor weakness or any dysfunction along the bowel or bladder. Now, modalities differs according to the surgeon and the clinical condition, but generally it could include decompression along with fusion of the spine. Now, the decompression, the fusion technique is usually done posterolaterally, and the indication includes if there is a preoperative assessment which reveal if there is any instability of the spine. It could be also caused by any pars defect, and other indications include spondylolisthesis around due to degenerative or ischemic causes. Other indications would include symptomatic radiographic instability. Now, other modalities for this type of condition is the laminectomy and also partial medial facetectomy without any fusion surgery. Now the pros is that you can do it for a stable spine and the spine remains stable without any fusion, but the cons would be including residual foraminal stenosis. This is a picture which reveals the region of where the pedicle to pedicle decompression is usually done to relieve all the compression around the spinal canal. Now first we start with removing the spinous process, and then we go on to remove the lamina to the insertion of the ligamentum flavum here, and then we move on to preserve the pars interarticularis, and then we also decompress the exiting nerve root here or decompression of the pedicle above. Then we continue to decompress the pedicle below, followed by decompression of the lateral recessed area, and then last, make sure that there is no disc herniation. You need to look anterior to this spinal cord here to make sure there is no disc herniation that compress this cord from the anterior aspect. Now afterwards, the post-management program should include an intense rehabilitation program. Now the complication for surgery could be a major complication such as wound infection, pneumonia, renal failure, or even neurologic deficits. Now the minor complication may include urinary tract infection, anemia, or even sometimes confusion or psychiatric symptoms. Now the prognosis according to the SPOT, or also known as the Spine Patient Outcome Research Trial, it shows that around 4 years of follow-up, significant improvement in the primary outcome measures for operative group is compared to the non-operative group, which shows that the outcome is generally almost the same for the operative as compared with the non-operative group. Now for the rehab, you could do a comprehensive rehab which includes these 4 phases. I will just quickly show you this table here. The first stage, the damage that occurs at each stage of the spine instability. We have made a discussion regarding the spine stability in our previous video, which is in the spondylolisthesis video. You could look at it there. We have discussed extensively about for the stages of stability, but generally for the degenerative cascade, the stage of instability can be divided into several stages, which is starting from the dysfunction stage, where there is only some inflammatory irritation around the vertebral disc with only minor changes at the facet joint, moving on to the stage of instability, where there is already chronic shortening fibrosis and also moderate cartilage degeneration at the facet joint. And it generally would end with the stage of stability, in which there is already significant bony overgrowth, or as evidenced in the radiograph as osteophytes. Now these findings would suggest that our body has done its natural course. It has tried its best to restore the stability that is lost during these 2 stages. Now for the phases of the rehab, generally during the phases of rehab, we want to first decrease the level of the pain that the patient experiences, and afterwards we would try to do a very basic exercise such as isometric exercises along with some spinal stabilization exercises, and followed by walking program if the patient is able to do so. Then we could only, after the patient has confidence in doing all that, the next phase would be for doing a resistant exercises, where the patient's muscle is being stimulated further to increase its muscle power or muscle strength. And in the end of the rehab phase, we need to do a progression of all those exercises that we do before, but more specifically, we need to evaluate carefully for their functional capacity, and also we need to tailor their needs for their special activities, such as going back to the home, going back to their working environment, or even engaging some sport activities. Now, that would be all for today's discussion for the lumbar canal stenosis. Be sure to check out my other videos for the evaluation of the spine stability, which is also connected to this current topic here. And if you like this video, please hit the like button and please hit subscribe button for more videos regarding the orthopedic world. Thank you.